Now, my brief here is to talk about use and abuse. And I have to talk with our professor of medical ethics, who also happens to be a Jesuit priest, about this title. And he said, well, it's actually quite well known since the Middle Ages. Use and abuse talks and orations and dissertations were very popular in universities. And he says it's a state-of-the-art lecture with a moralizing component. So you have use and abuse of statistics. Nietzsche wrote about the use and abuse of history. Harvard Medical School has a book out on alcohol use and abuse. We discuss more of this tonight. And the psychosomatic people have a cycle of abuse in relationships and families, a honeymoon period, tension building, and explosion. So we go through all this as far as Doppler is concerned. Now, Christian Doppler would have been thrilled if he had had such an audience when he first presented his paper on the Doppler effect. He had an audience of 5 people plus a secretary who was taking notes. But very soon, the effect he had developed spread all over the world, and nowadays we use it everywhere. We are all familiar with the echo of ships, and fishermen in the audience will certainly have a fish finder. Now you can throw in your line where your ultrasound tells you you're more likely to find fish. And it all comes down to that very same effect, the Doppler shift, a difference in frequency. Depending on the speed of sound you send in, the speed of the object of interest, the speed of sound in the tissue, this applies to medical Doppler, and the angle of intonation. So we get the actual velocity only with a zero intonation angle, and quite obviously, it always boils down to this equation. We get low frequency transducers. With these we can measure higher velocities. Now, we're all familiar with this application of the Doppler effect. Here, the difference between outgoing and incoming velocities are immediately translated into pound sterling or euro or whatever currency you're using. And amazingly, it's a pure trick of nature. In medical Doppler, the difference between outgoing and incoming frequency, they're both in the thousands of hertz, absolutely inaudible even to the most proficient bat or dog, well outside the hearing range, is at the frequency that we can hear. So the characteristic Doppler sound, that swishing noise, is actually not a heart beating. Our patients and often we ourselves have this illusion that we are listening straight into the heartbeat. We're listening at the difference between the sound, the ultrasound we send in, the ultrasound that gets out, and the difference is so small that it becomes audible for our pedestrian ears. Now, the Doppler cockpit of our Doppler machines. We go through these things. We have a gate. We have a knob to set the gain. We have usually a toggle, sometimes a knob to change the pulse repetition frequency. We have a wall filter switch, and we have a tool to modify sweep speed, and also the aspect ratio and the hertz selection. We should know these things where they are on our ultrasound machines, as we expect the pilot to know what all these dials and knobs on his or her cockpit mean. Now, let's start with the simple things. The direction of flow. Conventionally, red is up and blue is down. You can easily switch the invert button, and then it's exactly the other way around. But you must know that you have done it. You must know how your machine is set. Always know which way you're looking. And on all Doppler machines, you have this icon on the left where when red is pointing up and blue is pointing down, the setting is correctly. If for some reason you switched it, then of course the red is below and the blue is up. Now, the Doppler Gate, also quite an important feature. When you have a small vessel, like in this case the Ductus Venosus, which has a lot of interfering noise from neighboring vessels, you need a small gate. And we have a large vessel, like in this case the descending aorta. Be sure you have a large gate, you include the whole vessel. Now, the gain is one of the most difficult knobs to get accustomed to and acquainted with. If you have a too high gain, the signal gets lost in too much noise. If it's too low, you don't recognize the signal. And in color Doppler, the easiest way is you start with a gain that is so high that you see nothing but speckles, and then turn it down slowly until you have the impression, now I have a representation of the vessel in a color, in an intensity that I like. And what you're manipulating with this gain knob or toggle is the signal to noise ratio. So you're really at the heart of the representation of the Doppler wave on your screen. Now, PRF and aliasing. Maybe you've often wondered, and when watching television, why the spokes of a stagecoach in a western turn backwards and not forwards. It's something to do with the way it's being filmed, but that same physical effect, the pulse repetition frequency, comes to bear. And the pulse repetition frequency must be twice as high as the maximum expected Doppler frequency. Otherwise, your Doppler wave simply turns onto the other side. Now, a very useful tool, not so much for obstetrics and gynecology, but very much for our colleagues in neurology, vascular surgery. They always work with a wall filter. It's also called, depending on the product you use, it's called high-pass filter or wall motion filter. One of the difficulties in ultrasound nomenclature is that some of the names are proprietary. Another company invents a different name for the very same thing, which is, for someone who is starting to be familiar with it, often quite confusing. Now, a wall filter gives a better signal quality by dampening low-frequency noises. On the edge of a vessel, for example, a descending aorta, you always have noises created by the movement of the vessel wall, and that is something that is disturbing, creates a blurred image, prevents you from getting good indices. And that is also at the same time the great disadvantage. Low frequency of the vessel you're insonating get wiped out. So a wall filter set too high can give you an appearance of a loss of flow at low velocities. And my advice in obstetric studies, never set the high-pass filter at velocities higher than 100 Hertz. This was a case where a badly set wall filter had some bad consequences. This was a case of a very severe case of listeria infection at 27 weeks. You see a reversed flow of the umbilical artery, and the study was repeated a few hours later, and then the results said, oh, the reverse flow has disappeared, it is only zero flow. Actually, the wall filter had been set too high, and all the lower frequencies had been wiped out. Now, in this case, the woman who was a doctor herself definitely did not want to have any intervention, so no court case or anything resulted from it. But it is quite a disaster when the next morning you see a patient where the evening before you thought it had improved, that the fetus is dead. And this is really purely a mistake based on a not so good application of a technical feature of the ultrasound. The ultrasound at cockpit is really challenging, and please get out the manuals I often visit other hospitals, and what amazes me most when I ask, where do you keep the ultrasound manuals, there's scratching of heads. So lots of time they're still in their plastic sheeting together with wonderful teaching CDs somewhere in a drawer in the ultrasound room, and I've seen hospitals where all the manuals are kept securely locked at the technical department of the hospital, and no doctor ever sees them. They have greatly improved these manuals, so take your time. If you get a new ultrasound machine, it takes at least 1, 2, 3 hours to get through these manuals. Check all these features that I have given you, like the gain, like the pulse repetition frequency, like the sweep speed, how you can modify them on your ultrasound machine, and then you'll really feel competent. It's a bit often when you have a new ultrasound machine, you rent a car you've never driven. If you're used to right-hand driving and you're here in Britain, suddenly the steering wheel is on the wrong side, and the gear shift, the backwards gear, has a little ring to pull up to get it. You've never seen it. So the same thing happens to you with the new ultrasound machines. I'm quite often in court as a legal expert, and a lot of ultrasound-related lawsuits happen when people suddenly are confronted with a new ultrasound machine. A company puts new ultrasound machines for one day for testing into a department. Nobody knows where the right applications are, and this is the day that severe malformations are overlooked or very severe retardations on Doppler are not properly assessed. Now, the sweep speed and the aspect ratio, size matters. Also in ultrasound, what is interesting to you should be big. If you're interested in the Doppler wave, don't have a tiny little wave like a postage stamp size at the bottom of the screen, but know how to increase the size, at least for the duration of your study. Now, the next thing, you're now familiar with the Doppler cockpit and the various applications to improve your image, to get the right information out of your image. And we come to the indices. Now, traditionally, there were these three indices, RI, PI, and SD ratio. They're a qualitative tool of analysis of signals, and they make you a little bit, not completely, independent of insonation angles. Now, the first ever index was the resistance index by Pourcelot. Also at that time, it was only possible to measure absolute velocities. Here, the higher the resistance, which actually in pulsatile flow should be called impedance, but in day-to-day jargon we always speak of resistance, the nearer it gets to 1. So the really difficult, the diagnostic difficult cases are all squeezed into that narrow bracket between 0.92 and 1. The next one, a few years later, was the pulsatility index, when it became technically possible, to fit out the ultrasound machines with a feature that was able to measure mean velocity. You still have systole and diastole, but you divide it by the mean velocity over a given period. Now, the great advantage of the pulsatility index is the higher the resistance or impedance, the higher the index. So a pulsatility index of 2.2 is something really bad, and you react to it. And then finally there's the SD ratio, also known as the AB ratio, which is just a simple division of the systole by the diastole. And here the problem is that the higher the resistance or impedance, the more infinitesimal the index gets. Now, if we make a qualitative judgment on these indices, which are themselves qualitative appraisals, which index is best? The pulsatility index gives you the best hemodynamic information, even gives you a reproducible number in reverse flow when the RI is 1. However, there's one disadvantage: the mean measurement, particularly automated mean measurement of performed on many machines, is quite unreliable. Torvald Kieserud did some interesting studies on this. So I personally, when I'm in doubt, I always use the manual tracing when I'm doing the PI. Now, which index is the worst? The SD curve. It gets infinitesimal reverse flow, has no Gaussian curve, and has a variability which is 10 times higher than the Artery. Also, in some parts of the US, it's still being used a general cutoff ratio of 3, after which pathology starts across the gestational age, which is not even in correspondence with what the original authors and many others who use the SD ratio published. Now, there is also from the early 80s a Swedish alternative to indices, the blood flow classes, where you are eyeballing the Doppler curve. In this case, the descending aorta or the umbilical artery, and you see a relatively high diastole is normal, and blood flow is class 3. Reverse flow with zero flow is abnormal. However, this has really never caught on. I've only seen it in Sweden and some places in Poland. It's quite useful, but worldwide the most accepted form of index is the pulsatility index. Now, we have to look at the safety aspects, particularly of Doppler. And there are two items, the thermal index and the mechanical index. Now, these must be shown, according to the FDA, on the display of all ultrasound machines. These are these little figures and letters and acronyms that are draped around the framework, the frame of your ultrasound screen. This is the one you really must know what it is, the thermal index. It shows the probability of tissue warming inside tissue due to ultrasound. And the TI of 1 means a warming of 1 degree Celsius in the insonated area. The mechanical index is not so important for us in obstetrics. This shows the likelihood of the formation of cavitations in tissue. Now, for cavitations, for gas bubbles to implode, we are lucky enough, we are not using enough energy. Now, there's a very low risk of cavitation forming, but in the thermal index there is a linear increase with the duration of insonation. The risk of warming in a tissue is lowest in B mode, higher in color Doppler, and highest in spectral Doppler, depending on the dwell time in the area, and also very much on the interacting bony tissue or tissue bordering on bone. So if you spend a long time doing the middle cerebral artery, which is embedded in bone, really lying on top of bone, you have a very near vessel and bony interface. So this is one of the areas where you're most likely to create a heating effect. Now, the World Federation of Ultrasound Safety Committee has recommended maximum exposure time in minutes with a TI of 0.7, 60 minutes. Now, 0.7 is a normal TI in a B mode or a three-dimensional ultrasound, and 2.5 of 1 minute. Now, 2.5 you can quite easily reach by switching on the Doppler knob. A normal BA mode image has a low TI. Also a 3D image has a low TI. You triple the TI the moment you switch on the color Doppler. And in spectral Doppler, the TI moves very quickly from 2.5 even all the way up to 4.2. Now, one of the problems is that many ultrasound companies try to wiggle out of this obligation imposed by the FDA, and they show the TI only during active insonation. Now, everybody who does ultrasound knows that usually you are very busy looking at the ultrasound signal, looking if the gate is rightly placed, and you're not so much used to looking at the how these tiny letters in the frame change. If you put the freeze button in these ultrasound machines, the TI disappears and can thus not be documented. And tomorrow and on Monday there is a safety meeting at the Ultrasound conference in Edinburgh, where we will also discuss these problems with industry representatives. We must know how much energy we impart. Now, if you look how also a loosening of regulation has led to ultrasound machines with ever higher sound energy output have been allowed on the market and for use for application in obstetrics. This is quite a change. Sorry, a German word crept in here. If we just calculate the ultrasound energies we do in everyday scanning, you take 1 minute for a femur, 1 minute for a DBP, 1 minute for abdominal circumference, and at 720 milliwatt per square centimeter, you get an added 2,160 milliwatt per square centimeter distributed all across the fetus. If you switch on the Doppler, a 10-minute ductus venosus and a tricuspid valve, they cause 10,800 milliwatt per square centimeter across the whole length of the sound beam through the fetus. There's often an illusion to believe that the sound activates only here where your gate is placed, which is of course not the case. If you think about it physically, it's across the length of the beam, of course, with the corresponding attenuations through the tissue. Now, the same slide as before, only in a more readable way. 3-minute biometry and 10 minutes Doppler. In the pre-93 ultrasound equipment, you had this maximum energy, post-93 in B mode this, and with Doppler we are here. Now, there's great consensus in the recommendations and guidelines of ISUOC, American Institute of Ultrasound Medicine, European Federation of Ultrasound Societies, and the World Federation. Ultrasound on pregnant subjects must be performed by trained staff, and operators must know potential risks and keep an eye on TI and MI during ultrasound and try to keep exposure time low. So, when you go home on Monday, sit in front of your ultrasound machine, just keep an eye on your TI and MI when switching from B mode to Doppler. Just some tips: in the GE machines it's on the right edge, in the Philips it's on the top, a Loca it's below right, and whatever machine you're using, look where it is and see how it changes when you put on the Doppler. Now we come to the application of all this. We come to the center of the use and abuse topic of my talk. On what do we base our decisions in obstetrics? There's a saying that the man with one watch knows what time it is, and the man with two watches is never sure. And now in obstetrics we have watches on both arms, each one giving a slightly different time. It's the predicament we've gotten ourselves into with all the various appliances we use, and we're always trying to find out how the fetus is doing. Just a few decades ago, Leopold's maneuvers and auscultation with a wooden stethoscope were the most advanced methods of prenatal diagnosis, and in many parts of the globe they still are. There's a wonderful historic exhibition opposite the cloakroom, which I invite to look at in the breaks. And we have seen a sweeping introduction of disruptive technology. This were the first women in Uruguay in the 1940s on whom the first CTG machines were tested. Native Americans who got free treatment in a hospital if they subjected themselves to these examinations, with often poor organizational arrangements in our labor wards, clinics and offices. With many of us, I remember when I was in training, we had to do fetoscopy of practically every patient who came in and who had a minimally open cervix. We also spent a lot of time doing these things, and that always gave confusing reading. Now, this is our strongest weapon in the battle. And Geoffrey Dawes, many of whom you know from literature, quite cynically said obstetricians are hypnotized by the idea that all risk situations could be assessed by one single test. And in prenatal medicine, just as in postnatal medicine, we will have to use several tests simultaneously. And in our particular situation, we're always between GCP, evidence-based medicine, and fear of being sued. Frequency of assessment, serial growth, AFI, Doppler, CTG, biophysical. The question is quite often what prompts delivery and when. And Jim Thornton from Leeds said a few years ago, if you deliver too early, you get a bottle of whiskey. If you deliver too late, you get a lawyer's letter. Now let's look at our different watches and try to make the most of the information they give. We start with conventional cardiotocography, fetal heart rate monitoring. It's still the everyday workhorse of fetal surveillance, and often the entry port to more sophisticated technique. And usually a non-reassuring CTG pattern sets in motion a trail that leads where to. The trouble with conventional cardiotocography is it's a diagnostic system that was developed for fetal monitoring when labor had set in and birth was in progress, with diagnostic scores developed for subpartum monitoring at term. It's very widely applied in the second trimester of pregnancy. You have a potential for abuse. You become a slave to decelerations and do the emergency cesareans in half of your patients. And afterwards you have done so many emergency cesareans in healthy infants, you're so disappointed with CTG that you don't believe whatever it shows. Both of it is an abuse of the technology. Now the second watch is conventional B-mode ultrasound. Usually a suspicion of growth retardation combined with oligohydramnios, reduced fetal movement pattern, has the same effect as a non-reassuring CTG. More refined and more sophisticated tests are performed. Now Henk Waldenburg, my former boss in Rotterdam, said babies come in sizes like t-shirts, small, medium and X large. And one of the most difficult tasks facing us is recognizing the healthy but small fetus. It's as important as being able to recognize the small because malnourished fetus. We have these distinctions: the constitutionally small for gestational age fetus, what you call SGA, and the growth-restricted fetus in utero, who we say has not achieved optimal growth potential, and this IUGR is associated with increased perinatal morbidity and mortality. Now, one of the most frustrating things in obstetrics is the difficulty of separating these two entities. There's an enormous overlap between healthy SGA and hypoxic, infected, sometimes aneuploid IUGR. A single measurement may identify a fetus at risk, but only 50% of these have proven growth restriction postnatally. The 1980s concept of a symmetrical and asymmetrical definition of IUGR has not really proven to be helpful. Rora's ponderal index in newborns is used by pediatricians as an indicator of fetal growth status, but it can only be used once the infant is born. And in a study by Wiener, made many years ago, 40% of babies born below the 10th centile had normal ponderal indices, and 50% identified as growth restricted by ponderal index had a birth weight above the 10th centile. So really, there is something we have to get into, and we have to do better than we are doing now. Now, the common cutoff for SGA is a birth weight below the 10th centile. Now, only serial measurements of ultrasound can demonstrate growth patterns. So at present, the best definition of IUGR is a combination of reduced growth and placental insufficiency, which would then be abnormal uterine and or raised umbilical artery, PI. Now, around term, this is one of my favorite graphs. There is a nonlinear relationship between birth weight and risk of adverse pregnancy outcomes in term and post-date pregnancy. So you see the growth retarded fetus that made it to term is in great danger of having a suboptimal outcome, as is the macrosomic infant. So quite obviously the infant between 3 and 3.8 kilograms has the highest expectation of having a normal delivery. I advise you all, when you go home, to check your growth charts. Are they relevant to your specific obstetric population? Ethnic mix, socioeconomic status, altitude, and location. For decades, the Huntsman charts had a big mistake at 27, 28 weeks until a diligent medical student recalculated them for her thesis. Now, what is the potential for abuse in conventional B-mode ultrasound? You use reference curves based on Scandinavian fetuses and newborns to form biometry on the fetus of an Asian lady with a height of 148 centimeters. You create a false positive. And the even bigger mistake is you recalculate gestational age on a growth retarded fetus by making a wobbly approximation between parietal diameter and female age, and you create a false negative. Now, the watch 3 is the umbilical Doppler. This technique has reached the status of everybody does it, as the CTG in conventional B-mode ultrasound. Now, we all know that an absent or reversed end-diastolic flow signify at-risk pregnancy. It is really an evidence-based obstetric intervention. Umbilical artery Doppler, the use of umbilical artery Doppler reduces perinatal mortality, but that is the big problem. It does not tell you when to deliver. In ideal circumstances, umbilical Doppler is an AWACS early warning system. It alerts you to possible changes when CTG and B-mode can still be normal. Now, the potential for abuse in umbilical Doppler is you measure at right angles to the flow curve and you get a low diastole, you get a false positive. And you're enthralled by normal umbilical artery flow when everything else deteriorates, particularly later around term. You can always, in a really bad fetus, you can still have a normal umbilical artery Doppler and thus create a false negative. Now, the other arterial vessel, the fourth watch on our forearm, the descending aorta and the middle cerebral artery. This was one of the first publications by Arabin and Sarling in 1987. Now, the most widely Dopplered vessel outside the umbilical artery is the middle cerebral artery, both for its pulsatility index, which increases when the fetus deteriorates, and its peak systolic velocity, which increases when the fetus goes anemic. The simple rules of middle cerebral artery Doppler, as they are applied every day, is a high systole anemia and a high diastole brain sparing. Here you have a high middle cerebral artery velocity in a fetus with parvovirus infection, and the changes in fetal cerebral hemodynamics during hypoxia are that the vessel diameter and volume flow increase and PI and RI decrease. So, simply speaking, the brain throws wide open all the vessels that are narrow and tries to extract the maximum of oxygen. Now, Zico Serjon has done and is still doing a long-term study of infants that were born in the 1980s with brain sparing, and he could show that brain sparing results in a better outcome for motor development in growth retarded fetuses, but in a worse cognitive outcome. All these babies will not be rocket scientists, so we're still very much challenged to find the right place and the right time to deliver them. Now, in cerebral artery Doppler, there's a potential for abuse that you mistake the term effect at 40 plus weeks for fetal hypoxia and brain sparing, and you create a false positive. And also you push so hard on the fetal head that the diastole decreases and gets normal, and you create a false negative. Now, the Doppler of maternal vessels, there will be others speaking about it. The main problem is that we have at the moment a blurred diagnostic concept that makes a screening for preeclampsia that might manifest in a couple of weeks' time and actual diagnosis of dysfunctional maternal blood flow patterns, possibly causing fetal growth retardation. And I'm sure we'll hear more about this dilemma of maternal uterine artery Doppler. There is a host of uterine artery indices measuring the notch, the depth of the notch, etc. Now even Asterix has discussed the notch. The concept of a notch is a visible downward break of the continuity from systole to diastole, which generally speaking has a bad prognosis. But of course also here you have a potential for abuse. You see a notch at 17 weeks and tell the woman of imminent preeclampsia and fetal death. She goes home and Googles all these things, and her pressure gets so high that it becomes a self-fulfilling prophecy. Or you just don't want to give bad news and you see a notch at 23 weeks and you change the angle of incination so many times until you have the feeling it disappears, and you get the reading without a notch and you create the false negative. Now we come to the more advanced Doppler studies, the Doppler fetal veins. The Ductus Venosus is the most widely Dopplered vessel in the venous system and has evolved as a very useful tool to assess the time window between prolonging and actively ending pregnancy in a compromised fetus. I'm sure Kurt will talk more about this. Here's a normal Ductus Venosus. Here's an A wave all the way to the baseline, and this is a really bad reading of the Ductus Venosus with a reverse A wave. Here, this is one of the seminal papers that Kurt did with Yves Will and Katia Bilardo. The Ductus Venosus PIV showed the most promise in differentiating between neonatal outcomes. He will certainly talk more about this. Now, here you're really in your cockpit on the Doppler machine when you Doppler various vessels and you create an image of the pathophysiology from a moderate arterial redistribution with early venous changes to a severe arterial redistribution. You see a zero flow here, you see pulsations on the umbilical vein, a very high diastole in the cerebral artery, and reverse flow in the Ductus Venosus. I owe these pictures to Christoph Lees. Now, in the Ductus Venosus Doppler, there's of course a lot of potential to abuse for abuse simply because it's such a difficult vessel to find and assess. You mistake the inferior vena cava for the ductus arteriovenosus, which is the most simple mistake you can make, and you create a false positive. And the exact mirror contrary of that is you believe the bad A wave you get is just from the inferior vena cava, and actually you have the ductus venosus. So you really have to do a lot and many Doppler examinations and readings, and try again and again until you're familiar enough with this very difficult vessel. Now, summing up, we come to the Doppler of very special vessels, like the aortic isthmus. Now, the aortic isthmus is here. It's this part of the descending aortic arch just before the entry of the ductus arteriosus. And here's our friend Fouron. And his concept is that the quality in terms of oxygen content decreases through the mingling of blood from a reverse flow of the aortic isthmus wave. So that blood from the ductus arteriosus in the compromised fetus makes a hairpin turn and goes up to the aortic arch and mingles with the blood that should be coming down. Now, Dr. Mäki Kallio from Finland has written a wonderful thesis which you can download as a PDF from the internet on this vessel. So it has now been for a few years something like the new kid on the block, new parameter that could potentially help in monitoring of compromised IUGR fetuses. It is unfortunately a very difficult site to do Doppler on. That is the advantage, at least on the studies that have been done in France and in Finland and Canada, highly specific. However, when retrograde flow appears, the damage has already been done, and the preliminary stages are difficult to quantify. So we're again at this basic dilemma of perinatal medicine. So the potential for abuse is we simply don't have enough experience yet. The difficulty of finding the vessel already has a lot of abuse potential. Now, another watch are special CTG applications like the KCTG, a feature that nobody noticed, where the fetal movement patterns is printed on the strip. Then there is the STAN technique, Oxford and Quinnetic. They are at least techniques primarily developed for intrapartum monitoring that might have the potential for monitoring the compromised fetus. I'm personally very much a fan of the Oxford system, which was developed for use in pregnancy well prior to the onset of labor. And there the concept of short-term variabilities, the time difference between individual heartbeats is highly predictive of fetal acidemia. Now, the dilemmas in growth retardation are, first of all, how to monitor. We have a lot of tools to monitor, and then after we have all these often conflicting readings, the question when to deliver. Now, in an editorial opinion published a few years ago, 7 years ago actually, Romero, Kalash and Kada wrote this: it is still very difficult, and unfortunately over the past 7 years this editorial could be written today for the next issue of the White Journal. Nothing has changed, and we're still working on it. Hopefully with the truffle study in a few years, when these results come out, we're a bit nearer to a solution of this problem. Now, this was the state-of-the-art lecture with a moralizing component. Doppler in obstetrics has a lot of potential for use and abuse, and the best antidote against abuse is knowledge, understanding, and studying. And I'm quoting from Christian Doppler himself in his own handwriting: the most rewarding researches are those that by giving joy to the thinker help mankind. This is Doppler with his family. And finally, I invite you all to come to Austria for our, in March, also together with Kotecha and a few people who are here, our annual snow week of Doppler in Lech. Thank you.